A very good morning. Anu, please raise your hand. Anu and Ramyashri. Okay. Can I ask the persons at the timer desk to set the timer for 30 minutes? We are given 40. Please set it at 30 so that I have an advance notice for the next 10 minutes. Okay? 30 plus 10. Thank you. Yeah. You can, whoever is planning to present can present the case.
Good morning. Presenting the case of a 14-year-old student, female student from Malappuram, who complains of deformity of upper back since past 1 year. She doesn't have a history of pain, difficulty in walking, numbness, trauma, or difficulty in lying supine. There is no history of recurrent aspirations or respiratory tract infections. She does not complain of breathlessness or palpitation, or loss of consciousness or swelling of limbs. In the past history, she does not have any significant past illness, no history of heart disease, seizure disorder, tuberculosis, bronchial asthma, or previous surgical or anesthetic exposure or radiation. There is no history of drug or food allergy. On personal history, she sleeps in supine position on a flat mattress with normal sleep pattern. She has a mixed diet with the bowel and bladder habits normal. Menarche was attained at 11 years of age with regular 30-day cycles. Her last menstrual period was on 14 February 2023. Family history, there is no relevant family history. General examination. The child is alert, cooperative and oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing or lymphadenopathy. No thyroid enlargement. The skin, hair and nail appears normal. Vitals, pulse rate, 86 beats per minute, regular in rhythm, normal in character and volume. No radio-radial delay or radio-femoral delay. All peripheral pulses felt equally and bilaterally. Blood pressure, at 110/80 millimeters of Hg in the right upper arm in supine position. The respiratory rate is 18 breaths per minute, abdominothoracic. Her peripheral oxygen saturation is 99% in the room air. Her temperature was recorded as 98 degrees Fahrenheit.
Her height is 152 centimeter, weight is 50 kg, and BMI is 21.7 kilogram per meter square. Her airway examination, there is no facial deformity. Mouth opening is 6 centimeter, palate is normal. Malampati class 1, temporomandibular joint insinuates 1 finger. Thyromental distance is 7 centimeter. Sternomental distance is 14 centimeter. Neck flexion and extension is normal. Head to toe examination, his gait is normal. Position of head is central, normal hairline, no facial deformity. Right shoulder appears higher than left, prominent scapula on the right side. She has a converse curvature of spine towards the right, which is smooth. Lateral margin of trunk is asymmetrical. External genitalia and abdomen is normal. No tuft of hair or dimple. Skin is normal. No cuff hairlid spots. Extremities are normal. Local examination, inspection from back. She has a curvature of spine from T8 to T12 with convexity to right, and it has a smooth curve. Rib hump on the right from 8 to 10 ribs posteriorly. Left hip is high. From front, there is prominent right side of chest, anterior superior iliac spine high on the left side, no costopelvic ulcers. From side, there is no exaggerated lordosis or kyphosis. On palpation, all inspectory findings are confirmed. No local rise of temperature, no tenderness over the spine or costopelvic region, no limb-limb discrepancies. Right and left lower limb length is 81 centimeter. Plumb line from C7 does not cross the sacrum in midline. No signs of hyperflexibility of joints. Adams forward bending test. Right curvature persists. T8 to T11 ribs are prominent on the right side. Right scapula is prominent. In respiratory system examination, the upper respiratory tract is normal with a respiratory rate of 18 per minute. Respiratory movement is equal bilaterally. Chest expansion is 5 centimeter. No more vesicular breath sound bilaterally. No added sounds. Bedside PFT, Sabrasi's breath holding time is 34 seconds. Snyder's match blowing test is she is able to blow the match at 6 centimeter. Auscultation over trachea is 4 seconds. Cardiovascular system, pulse rate is 86 per minute. Blood pressure is 110/80 millimeter of mercury. JVP is not elevated. Precardium is normal. Apex beat is felt in left to fifth intercostal space in the midclavicular line. S1, S2 is normal and no murmurs. Nervous system, his mental functions is normal. Cranial nerves is normal. Sensory and motor system is normal. Superficial and deep tendon reflex is normal and no cerebellar signs. Summary. It's a 14-year-old female with gradually progressive deformity of back for 1 year. On examination, there's right curvature from TA to T12 vertebra with gibbous deformity on the right side without any neurological or cardiopulmonary involvement. Diagnosis: it is a 14-year-old post-menstrual girl with right-sided thoracic scoliosis, probably adolescent idiopathic scoliosis, without any neurological deficit or cardiopulmonary involvement, posted for scoliosis correction.
Excellent. Please come and sit down here. So can we have Anu just give a 1-minute summary after the entire presentation? What concern of anesthetic concerns? What are the points you need to know?
Yeah, this is a case of 14-year-old post-menstrual girl who came with curvature of the spine.
1 minute. Don't repeat the whole history again. 1 minute.
Okay. Post-menstrual girl with a gradually progressive deformity of the spine, with a gibbous curvature towards the right at the level of TA to T12, with a gibbous deformity to the right. There is no cardiovascular, neurological, or pulmonary involvement.
Good.
Therefore,
I'm happy with that. Thank you very much.
Thanks,
Okay.
sir.
I need to know whether this child goes to school and what is
Yes,
her
sir.
activity at school.
He's going to school and he's doing shuttle or playing from the school.
So she's, not only good mentally, but she's also
Yes.
doing a lot of exercise.
Yes, sir.
So that is again a good sign for us, right?
Yes, sir.
Okay. Now, when you talk about, you gave the diagnosis idiopathic. So just for completion's sake, what are the types of scoliosis that we come across normally? And have either of you done cases of scoliosis?
Yes, sir.
Both of you have done.
Yes.
Okay. Can we have a hand raise in the audience of those who have done scoliosis cases? There's lots of extra help available if you need that. Okay, fine. Go ahead. Yeah.
So scoliosis.
This is a real case that you did? One of you? Or this is a good? Yeah.
So scoliosis can be structural, non-structural,
Okay.
primarily. So structural scoliosis is the one that requires immediate surgical correction. A non-structural scoliosis is the one in which the scoliosis is only because of the posture, and it can be corrected as the child lies supine or bends forward. It is usually due to a sciatica or a hip contracture, or it could be similar reasons where contracture or anything. And structural scoliosis can be further classified on the basis of its location as well as etiology.
Okay, I'll stop you here because sometimes as examiners we know how much you have read, so we don't want to waste time whenever we look. Even in the exam we'll have a very finite time. Okay, so now this child is scheduled. We go straight for the peri-anesthetic management. Okay, child is scheduled for a scoliosis correction. What type of surgery is done in your institution for scoliosis?
Posterior spinal fusion and instrumentation.
And instrumentation. Okay. So, keeping that in mind, how would you evaluate this patient's physical condition firstly, and also you go for the other investigations that you would like to do? You tell us about the physical examination. How do you exactly judge how bad the scoliosis is?
Okay, to judge
You
the
told us there is no cardiorespiratory involvement. Okay. Do you need to go a little more into that?
Yes, sir. I want to know while examination, I want to know the level of the curve and the severity of the curve as well. Also, the progress in history. I already.
How would you do that?
So, using a corpse angle.
Okay.
Corpse angle is a measurement taken on X-ray, and X-ray PA view of the spine. I identify the.
Can you go put up that X-ray? Yeah.
I'll find out the most tilted vertebrae in the uppermost and lowermost level, and draw a line parallel to the superior border of the uppermost vertebrae and the inferior border of the inferiormost vertebrae. Now I'll draw perpendiculars from these lines, and the angle at which these two intersect is referred to as a corpse
Have you
angle.
done that on this X-ray?
Yes, sir.
How much was it?
40 degree. 40 degree.
40 degrees. Now, what is sacrosanct about this 40 degrees? Are we worried at 40 or worried even if it's more or less? What is it?
We should be worried if it's increasing. Definitely at 40 degree, we need to do a corrective surgery. So the implications include, if it is less than 10 degree, it's found to be normal. If more than 25 degree, there could be echocardiographic evidence of pulmonary artery hypertension. At 40 degree, more than 40 degree, you advise a surgical correction. If more than 65 degree, there will be restrictive lung disease. If more than 100 degree, they could be associated with a severe cardiopulmonary involvement.
Okay.
And more.
So, from the history, we know this child is quite active. So, it correlates with the 40 degree Cobb's angle,
Yes.
right? Can you go on to the investigations you would like to do before you take up for posterior spinal fusion?
Yes, sir. I will first of all do the routine CBC, complete blood count, including hemoglobin, total count, platelet count.
I'll assess the hemoglobin because there is more. I am expecting.
What was the value in this patient? I forget. Hemoglobin?
12, sir.
12, okay.
So I'm expecting more blood loss during the surgery. So I want to look the hemoglobin value. Then if I'm planning for autologous transfusion also, this values is important. Then total count to assess for the respiratory infection or the active infection, which
Are they
is
more prone to infections?
yes, sir. They
Okay,
are
right. She's not. Okay, so total TLC is normal. Okay.
yes. Then I will look for the platelet count. This baseline values is needed. Then I will do random blood sugar. Then RFT, including urea as well as creatinine, serum electrolytes, including sodium as well as potassium, liver function test to assess the baseline liver status as well as to assess for the nutritional.
On all these, you consider mandatory for this child.
Not, sir, but I want to assess for total protein.
So what do you consider mandatory? This will be going through the whole Dobby list, you know.
Okay, sir.
Right?
Blood grouping and typing is mandatory because there is more chance for intraoperative bleeding as well as we need to transfuse the patient. Next, I will do a chest X-ray PA view to assess whether there is any cardiomegaly, to assess the curvature of scoliosis, and if there is a right-sided scoliosis, there are more chance for cardiovascular involvement. And ECG I will take to check for the cardiovascular involvement and as well as right ventricular hypertrophy and P pulmonale. Then I will take a pulmonary function test, sir, to assess because there is restrictive lung disease which is very common in patients with scoliosis. So I will do a pulmonary function test. Echocardiography will be done for these patients.
Right. So with all these investigations, do we have anything suggesting involvement in this patient? If that is so, please tell me you say hemoglobin 12 gram%. Anything that is of worry to us? In all the tests that you've done, you said PFT, you said
Most of this
echo.
is normal.
They're normal.
The PFT showed us mild restrictive pattern. That's all, nothing significant.
Mild restrictive pattern. Okay. Is it commensurate with what you see at 40 degrees of Cobb's angle? Do you see that much of respiratory involvement?
No,
Not
sir.
necessarily,
Not
sir.
necessarily. But maybe because he's a child, you could not evaluate properly. Right. So now we are ready to essentially take up this child for surgery. Anybody in the audience wants to ask for any more investigations very quickly? Otherwise, they're going to go on to the management. Everybody's happy. Yeah. Okay. So who's going to tell us about the pre-operative preparation part of this patient? One of you, yeah.
I'll prepare the patient,
And you go on to the intraoperative, okay?
I'll prepare the patient psychologically and physiologically for the procedure. I will do an incentive spirometry, chest physiotherapy, as well as breathing exercises for this patient. If there is an anemia, for this patient there is no anemia. If there is, I will correct it. And if I will also assess the nutritional status of the patient. Then in the preoperative day, I will ask for the written informed consent. Then I will explain the patient regarding the procedure, as well as I will ensure about the wake-up test, which she is going to perform during the procedure.
Do you do it in your institution,
Yes,
the wake-up
sir.
test?
We are
Okay.
using. We are
So
routinely
you would
doing.
probably prepare this child with the
Yes.
details of the wake-up
Yes.
test.
I'll
Okay, we'll
ensure-
come to that little later intraoperatively. Okay.
I'll ensure about the wake-up test, that is, there will be no pain or discomfort during the procedure.
Okay.
I will get orders for nil per oral, that is 8 hours for solid food and 2 hours for clear liquids. Then I will arrange the blood because there is a lot of blood losses expecting in the surgery. I will arrange for the blood, and I will.
So I think we have a session on blood conservation or blood management tomorrow by Dr. Krishna. I think that will be dealt with in detail there. But what do you follow in your institution as far as blood management is concerned? Do you do anything specific or you just give blood for blood?
Just give blood for this patient.
Blood for blood. Okay, fine. So you you grouped and
Yes.
cross-matched enough blood and blood components. Okay.
Then I will give aspiration prophylaxis, tablet pantoprazole 40 mg, 1 HS, one in the night and 1 in the morning. Tablet metoclopramide 10 mg, 1 in the night and 1 in the morning. Alprazolam 0.25 mg.
Her weight is
HS.
50 kg, right?
Yes, sir. Then on the morning of surgery, I'll check whether all the investigations, all the orders are followed properly or not. And I will check whether the consent is obtained or not. Check the compliance for the treatment, including the pantoprazole and Reglan.
Okay.
Then I shift the patient to OT.
Okay, so I think Dr. Anu will do that part now for us, shifting the patient to OT. Everything has been done pre-op part. Okay. Before that, I would like to know from you, what would you really consider as your main issues in this? She's a 14-year-old, 50 kg, almost an adolescent. So do we really have problems related to the child or a pediatric age group?
Not much.
Plus minus. You've seen the patient.
Yes, sir.
Okay.
Not much, but though she has anxiety, she's an adolescent who has a lot of anxiety. So pre-operatively, I already have counseled her about the
Okay. Have you
operative
counseled the
plan.
parents also?
Yes, sir. I have counseled the parents.
Done. What else? As far as the disease component is concerned, we've evaluated and realized that it's a scoliosis, all right, but not hampered or involved the cardiorespiratory impairment. And she's mentally normal. So that's fine. Then, how about during surgery? What are the issues that you have to keep in mind during surgery? You said posterior instrumentation, right? Okay.
Yes, sir. So
Just list out the problems and then we'll see how you'll tackle it. Okay.
the problems related to the patient, the surgery, as well as due to the anesthesia.
Very nice. Okay.
So,
Your classification is good. Okay.
regarding the patient, since this child does
It's always
not
good to think in a very systematic manner, then you don't forget anything, right?
So,
So
child,
with the patient, yeah.
with the patient, she has a scoliosis without much cardiorespiratory involvement. So not to worry much onto the child's part without any associated syndrome. So I don't have to worry about factors related to that. However, she is an adolescent. Management preloading drugs according to her weight, anxiety, resolving her anxiety issues.
Okay,
are
let's
of
go to
important.
pre-operative monitoring. Pre-induction monitoring and post-induction monitoring. What's your plan for monitoring? I'm cutting you short because we need to discuss as much as possible.
Okay.
We need to take this child through surgery and post-op, right? We don't have that much time, okay?
In the pre-induction monitoring, I'll attach standard ASA monitors, including electrocardiogram, peripheral pulse oximetry, NIBP in the beginning, and end-tidal carbon dioxide. And post-induction, I would also like to add invasive blood pressure monitoring, central venous pressure monitoring, urine output monitoring, bispectral index monitoring, as well as somatosensory evok potential, as well as motor evok potential monitoring in this child.
So you are familiar with all these
And
monitors?
temperature also, sir.
And all
Yes.
this is done in your institution?
Yes, sir. It's
Excellent. Okay. Right. So this child is on the table now. Okay. Not very anxious because you both have prepared her well. Okay. Surgeon is ready. How are you going to go about induction?
in
Monitors are on. Pre-induction monitors are on, as you said. Okay.
okay. After
But you'll need to put the monitors posteriorly or anteriorly?
anteriorly, sir, and
Initially?
because they are manipulating in the spine.
Ah, correct.
Yes.
Okay.
Okay, so after that, I like access a peripheral IV, which is a wide bore peripheral IV cannula will be inserted, and running fluids will be ensured. The patency is confirmed. After which, I'll pre-medicate her with injection midazolam 0.5 mg per kg, 0.5 mg, and then injection glycopyrrolate 0.2 mg, followed by injection fentanyl. And this patient is 50, so 2 mics around 100 microgram. And parallelly, I'll start with pre-oxygenation with 100% O2. Then followed by I'll prime her with injection at trachurium 0.25 mg, 0.2 mg, sorry 2 mg. And
What is the drug? Sorry? You're going to do induction with?
induction with propofol, sir.
Propofol, okay.
2 mg per kg, that is around 100. And then I'll ensure there is adequate ventilation, chest raise is adequate. Then I'll administer injection at trachurium 25 mg, and then continue back and mask ventilation.
The airway
Prepare
is
for
essentially normal, right? It is only involving the thoracic segment T8
yes,
to
sir, only
T12.
thoracic.
Okay.
So I don't anticipate a difficult airway here.
So you need to keep in mind sometimes if it involves the cervicothoracic region, that might also be an issue. But in this case, again, essentially clinically normal airway. Okay.
So then I'll proceed with direct laryngoscopy after giving a stress response attenuator like injection lignocaine. Following which I will attempt a direct laryngoscopy and a flexometallic.
What is the choice of endotracheal tube?
It's a flexometallic cuffed flexometallic endotracheal tube of size 6.5 millimeter for this child, sir.
Okay. Right. And the
Following
reason for
which-
that?
Because it's the surgery is performed in a prone position, and therefore I don't want this endotracheal tube to be kinked while positioning or throughout the intraoperative period. She's also being waken up in between surgery. I don't want her to bite the tube and block the airway. So I want a flexometallic tube for this child.
It's not right to think that a flexometallic tube cannot be bitten into. Right? It's got rings and space in between. So you might have to do something special to prevent that.
A bite block can
A
be
bite
applied.
block, okay, or a conventional bite block, or there are specific bite blocks available for that, okay. You can even keep a folded rolled gauze on either side over the molar so that it doesn't bite onto the tube. Fine, okay. Precaution, and what about the post-induction monitors? You will pass a urinary catheter,
Yes, sir.
an
I'll
arterial
insert an
cannula.
arterial-
Is a central venous, monitor mandatory? If you get two good peripheral IV lines, are you happy with that, or you still like to go for a central
I
monitor?
still like to monitor central venous pressure, sir, because in our institution it is a routine.
Do you do
practice.
ultrasound guided or you go blind?
Ultrasound guided, sir.
Okay, which route?
Right IJV. Engine jugular veins. sir, will be
Interjugular vein.
cannulate.
Okay, fine. So we have put in a central line also. Now,
Yes, sir. Also,
until now you've given as an analgesic, you've used
intrathecal
2
morphine.
microgram per kg of fentanyl. I'm concerned because we could have used something more also. You know there's going to be a lot of pain post-op, right? So would you like to add on anything?
yes, sir. We would like to give intrathecal.
Yeah.
After induction, we will position the patient because this patient have more anxiety when we are doing before the induction. So after induction, we'll position for the intrathecal morphine administration, 2 to 5 microgram per kg we are giving. For this patient, we are given 200 microgram intrathecal morphine, sir.
Intrathecal morphine.
So
Okay.
intrathecal morphine got severe post-operative
Right.
analgesia. We have got 24 hours of post-op analysis.
Now we have a group of very fussy surgeons. I don't know whether Krishna is still in the audience, who don't like us to do anything near the spine. They believe we are all infected and will introduce infection there into the spine. But if they agree, I think it's a good idea. Okay? Intrathecal morphine is an excellent
Otherwise, they
way
will
of.
put epidural, sir. Otherwise, they will put epidural catheter. That is more.
That will also come in the way. I think epidural is also not a very great option, but intrathecal morphine,
Intrathecal morphine.
is definitely an option. Okay.
And also, there is reduced chance of blood loss also.
Okay. Right.
So
Please go
I'll
on.
give paracetamol injection.
Can we give IV morphine? That they can't object, no?
Initially, we have given fentanyl IV, sir, 2 microgram per kg.
Fentanyl is
Yes,
given, but
yes.
would that last enough
No,
into
sir.
the post? You're going to have a lot of pain after the instrument, the spine, right?
So we give post-operatively
Your
injection
pain management must be proportionate to the pain that you anticipate. You shouldn't give a small dose for a
So I'll give
So such-
multimodal analgesia, sir.
multimodal. One of them was intrathecal morphine.
Then
What is
I
the other
give
thing you want?
injection paracetamol
Okay.
10 to 10 mg per kg.
What is the
IV.
advantage of a multimodal system of attacking pain?
In a
Because
multimodal analgesia, the pain pathway is being blocked at different levels. Therefore, it,
Excellent. Now you know the answer. I know that. I'm stopping there. Okay. So we are attacking the problem from different angles, and therefore your pain, the pain relief you will get, the quality of pain relief you will get is going to be much better. Okay. Right. Right. Let's talk a bit more about. You said you use BIS monitors and somatosensory evoked potential monitor. What does each one of these tell us?
so in this case, since we are planning for
What does a bispectral index tell us?
bispectral index tells us about the depth of anesthesia. In this case, in which we are using neurophysiological monitoring, we need to titrate the depth of anesthesia adequately because the anesthetic drugs interfere with the monitoring.
Are you going to continue with inhalation, or you got some other plan?
We prefer to continue with infusions, total intravenous anesthesia, if required. to
No,
supplement-
inhalation. Are you
No, sir.
induce
No,
the,
sir.
Are you going to continue? What is the gas mixture you're going to use to keep the patient anesthetized?
Initially, till the patient is positioned.
This is
prone,
important for us because why? Complete the sentence.
Because in neurophysiological monitoring, all potent inhalation anesthetics and nitrous oxide are known to interfere with the.
Right. So keeping that in mind, what are you going to choose?
So initially, till positioning the patient prone, we'll be administering oxygen plus nitrous oxide in a proportion 33 to 66, also with sevoflurane 2%. After which, after positioning in prone and ensuring adequate proper hemodynamics, we'll switch over to total intravenous anesthesia with propofol infusion, opioid.
Is this
fentanyl.
theoretical or do you really do this?
We really do
You do
this.
this. Okay. Okay.
And dexmedetomidine infusion as well, sir.
So do
Again,
you
we
keep
try-
a basal level of inhalation going?
No, sir, we don't.
Totally cut off the inhalation.
Totally cut off
So
the
what is your gas mixture going then into the lungs? Nothing.
Oxygen and air, sir.
Huh?
Oxygen and air.
Oxygen and air.
Air.
Okay. And you depend totally on total intravenous anesthesia.
Yes, sir.
What are the doses and drugs that you use?
Propofol at a low dose of 50 microgram per kg per minute, and fentanyl infusion, opioid infusion, would be about 2 mics per kg per minute. Sorry, 1 mics per kg per minute, and dexmedetomidine 0.5 mics per kg per minute per hour.
Okay. And you go by the BIS monitor. What do you keep your BIS index at?
Between 40 and 60, sir.
40 to 60. Okay, fine. So you're switching over to TIVA, right? Why did you not choose to continue with, suppose, let's see, we're not so far advanced. We don't have equipment to deliver specific quantities of intravenous anesthetic. Can I continue with an inhalation agent?
Yes, sir, we can continue at a MAC less than 1. All inhalation anesthetics
MAC
can.
less than 1. Or even, no, what is the cutoff below, where we need to worry about? Above which somatosensory evoked potential can get affected.
greater than 1 MAC, it will be affected, sir.
0.5 is the limit. Okay, so we really can't maintain an anesthetic. If you want to get good information from the SSCP, you'll need to bring down the MAC to quite low levels. Can you use nitrous oxide to
We
help
can
maintain the
use,
anesthetic?
but it's again controversial because nitrous oxide is not.
That's why I'm asking, because it's controversial. Yeah.
We can give, sir, then, but before spine manipulation, we can cut it down, decrease the concentration of nitrous oxide and continue with the same.
Right.
If it interferes with the monitoring, we'll have to switch to air.
So you can do a combination of the two also. Okay, inhalation plus total intravenous, not total, a partial intravenous anesthesia, if you can call that. Okay, you need to maintain the MAC at least around 0.33 also, and the rest you titrate with your BIS monitor and TIVA. Okay. What worries you? I mean, how do you coordinate the teamwork during SSCP? How many people need to be involved in interpreting somatosensory evoked potentials? Only you, or only the surgeon, or
No, the technicians.
how does
are
it work in your institution?
The technicians are the technicians set these monitors and they'll be
When do
monitoring
they
it.
warn you?
They will
Ramya.
warn me as at the time of instrumentation, sir.
Sorry?
At the time of instrumentation, they will warn us, sir. While
They put the monitors that time. They need a baseline recording. Okay. Then
so whenever they are in whenever they putting the pedicle screw, they will warn me that there will be reduced. Warn me about the
reduce
whenever there is a reduction in the amplitude as well as
amplitude.
increase in the
Reduction
latency.
amplitude.
They will
What else? Is that the only
increase
thing
in
you
the
look for?
latency. Increase in the latency.
Increase in latency and reduction in amplitude. So, if you're not used to that, if you're not doing that many cases as an anesthesiologist, you can't interpret all that. So, you do need a neurophysiologist to come along. I'm sure you have that in the team, right? Is there anything that we can do that can affect the somatosensory evoked potentials?
Most of the anesthetic.
Am I heard for most of the time? Yeah. Okay.
Yeah,
I suddenly heard my voice booming, so I was wondering. Yeah.
So almost all the anesthetic agents are known to interfere. Also, the physiological parameters like hypoxia, hypercarbia.
Okay, now I'm the neurophysiologist. I say there's an increase in latency and a decrease in amplitude. The surgeon gets all worried and looks at the anesthetist. What are you going to do?
I'm going to optimize the physiological parameters first, and then
So you can physiological alteration of what physiological parameters?
hypoxia. I'll make sure there's adequate oxygen.
What else? Just list them.
Volume.
Just list hypoxia,
Hypoxia, hypovolemia, and hypothermia, acidosis,
carbon dioxide doesn't affect?
Yes, sir, it has hypercarbia. all
When
this
you
like
say, okay, and blood pressure, okay?
blood pressure.
So you need to normalize all this. So the first step is the neurophysiologist will inform you. You need to normalize whatever is within your control so that it is not the anesthetic that is causing the problem, and then the surgeon will decide what to do. Okay, that's about. What else can be monitored other than SSCP? I know you've done a good discussion on SSCP, but what are the other monitors? You talked something about wake-up test. Do you routinely use it?
Yes, sir, we routinely do it in our institution.
Okay. Time to do wake-up test, surgeon says. What are you going to do?
Okay, I'll ask the surgeon to inform me prior.
Oh,
to
I'll
at least
correct.
20
I'll
minutes.
tell you 10 minutes from now I'm going to do it. Yeah. Okay.
So 20 minutes prior, I'll ask the surgeon to inform me if he's planning for a wake-up test. Then I'll titrate the anesthetic agent because I want to wake the patient up. I'll titrate the anesthetics accordingly to reach a BIS of at least more than 60. Then I'll make sure the operating room is calm and quiet, and I'll have attenders ready in case the patient is moving violently. Also, I'll have an attendant at the foot end of the patient so that the examination movement of the leg can be recorded. Now, if everything after this time.
I'm a bit confused about the timing, okay? As per my timer, we have finished 30 minutes. I can stop here also. How much time do we have? Over? 40 minutes over?
No,
10
sir.
minutes left, okay. Because my timer is just going to go another 15 seconds. We have 10 minutes more, okay. Go ahead. So we have 10 minutes more, right? Okay.
After which, when the BIS comes up to 60, I'll wake.
You're
the
not
patient.
heard. Even hardly heard here, yeah.
Okay, sir.
Audience won't hear you.
Okay, so once the BIS is above 60, I'll wake the child up. I'll call her by name and ask her to raise her upper limb. If she moves the upper limb, then I'll ask her to move both limbs. And if she moves both limbs, I'll deepen the plane of anesthesia and put her under deeper
Okay.
plane.
I give you a situation. Upper limb she's not moving, lower limb also she's not moving. What's your
That
interpretation?
means she's not awake, sir. She's still under deep anesthesia. So I have to lighten the plane of anesthesia and wake her up.
Okay.
And then
Other way around now. Upper limb not moving, lower limb moving.
upper limb not moving. That's
Not
not
moving.
possible, sir.
Why? How do they
Unless-
position your patient? So what are the
Okay.
problems of prone position? Tell me.
Okay, sir, that could be possible.
What are the
because-
problems of prone position?
Okay, problems of prone positioning can be from head to toe. As there can be compression of the eyes resulting in postoperative.
Very good. You continue, please.
During the prone position, expecting the compression of eyes, so we want to adequately pad the eyes. Then we want to make sure that there is no kink or dislodgement of the ET tubes.
Tube.
Then we
That's why
want-
you put a reinforced tube. Okay.
So then I want to place a bite block to prevent the bite over the tongue.
Oh, yeah.
Okay. Then
Come further down.
I want to avoid this flexion or hyperextension of the neck, and I want to make sure that there is no hyperabduction of the shoulders or hyperabduction of the there is no the
So you
arms are padded.
occasionally, very rarely, if there's too much compression over the brachial plexus, you
Plexus
can get that kind of a situation also. Okay. And of course, if both are moving, it's good sign. You re-induce the patient. Okay. Any other test that you can do without waking up the patient completely?
Motor evoked potential, sir.
Okay. What's the difference? Which area of the spinal cord is supplied by? What is the blood supply to the spinal cord?
Blood supply of the spinal cord is from anterior as well as posterior spinal
No,
artery.
hold it close. Hold the mic close. I can't hear you, ma.
Anterior spinal artery and posterior spinal arteries. The anterior spinal artery supplies the anterior 2/3, while the posterior paired posterior spinal artery supplies the posterior 1/3 of the.
Is that right?
Yes,
Are we getting the 1/3 and 2/3 wrong, or am I getting it wrong?
That's right, sir. Anterior 2/3 and posterior 1/3.
I thought the other way around. Okay. Anterior 1/3 and posterior 2/3. Okay. So, okay.
And so in the posterior 1/3, there will be sensory conduction of the sensory pathways. So
You are right. I take back my statement. You are right. Okay. What does the anterior spinal artery supply? I mean, what motor or sensory?
anterior supplies the motor, sir.
Okay.
And posterior supplies the sensory.
How many
cortex.
arteries are there? Posterior?
Paired, sir. So it's
Paired.
2.
Right. So, what are the sensations that are maintained by the posterior columns?
So it'll
What sensory?
Crew touch will be there, sir. Vibration, stereo.
You use the mic.
vibration,
It's
crow
not just a
touch,
discussion between four of us. Okay.
vibration, crow touch, and proprioception. We are in the posterior column pathways.
Okay. What are the other sensations that are missed by
Anterolateral pathway, there is pain as well as temperatures.
temperature? Right. So, why are we? Is it better to monitor both? Motor evoked potential as well as somatosensory evoked potential?
Yes, sir, it's better because the integrity of spinal cord can be lost in either ways. It could be a damage to the anterior spinal artery or posterior artery, or direct damage by the surgeon to the cord. It can be at either level. So
Right.
monitoring both is actually
Would be a good idea, right? Okay. Now, going to that one test that I was asking for, which you can perform without all this fancy stuff. Okay, somatosensory, motor, all that you forget. You said to do the wake up test, you need to wake up the patient. Is there any test you can do, to assess the same thing without waking up the patient? Tell me at lunchtime. Okay, let the others also think. Anybody in the audience? If audience has gone to sleep, okay, right. Will you look up and tell me?
yes, sir, sure.
I need to give you some homework. Find me at lunchtime and give me the answer. Okay. What is the test that is done? Okay. Not SSCP, not MEP, not the awake
Nerve
test.
stimulation, sir. Peripheral nerve stimulation, sir.
No, peripheral nerve stimulation will not help. What are we trying to evaluate? Peripheral nerve stimulation is there. You're only monitoring the neuromuscular junction, right? That won't help. Okay. We are monitoring. The idea of monitoring the spinal cord is to see whether the surgeon has caused any damage due to vascular impairment, or
Direct
you
neural
talked about
damage,
the screw, the pedicle screw placement. That also can cause direct injury. Okay, sometimes the surgeon is clumsy, not intentionally. They can directly traumatize the spinal cord also. Right, so a lot of things can happen, and that's the reason why we monitor the pathway. Somatosensory, essentially, where do you stimulate?
Somatosensory in the peripheral, it can be posterior tibial nerve or a median nerve or ulnar nerve.
And what are you looking for? Just trace the pathway.
Yeah, it will ascend through the spinal pathways into the sensory cortex, where we can record the same.
Ipsilateral or contralateral?
Contralateral.
Contralateral.
It crosses the same level. and it sets up-
Motor evoked potential, how would you do it? What is the concept of motor evoked potential?
In motor evoked potential, we are giving transcranial stimulation of the motor cortex, and we are getting the response in the food by then we were assessing the integrity of the spinothalamic tract.
Can we use muscle relaxant in that case?
No, sir.
You can't.
We are
So
not using.
that becomes a bit of an issue again, no? So depending on what center you're working at, you'll need to plan your anesthetic very well. Any particular concerns at the post-operative period?
Yes, sir. Pain is the most important concern. Pain. Also, post-operative nausea, vomiting, post-operative pulmonary complications because it's a long surgery, and she could have a pulmonary dysfunction. Therefore, prevention of atelectasis and pulmonary impairment should be taken into consideration. Also, the surgeon is working close to the mediastinum. He could also injure the pleura and mediastinal structures. So, careful watching for the respiratory signs are important. Also,
You routinely do a chest X-ray?
yes, sir.
You routinely do one,
Yes,
or only
yes,
when
we
there's a
do.
suspicion?
No, we do, sir.
Okay.
Before
And
she-
have you had any patients that needed to be ventilated following scoliosis surgery?
Yes, sir. The decision,
Especially when?
the decision to ventilate occurs decides preoperatively if the patient has a coexisting neuromuscular disease, if there is a severe cardiovascular impairment associated with congenital heart disease, if the patient is in heart failure, she has an obesity, or if the blood loss is
So
more than 30
more
ml
severe
per kg.
scoliosis with effects on the cardiorespiratory system, or if it's a neuromuscular disease that has led to this scoliosis. I think I'll leave the mic to you, Dr. Radha. You prepared your students very well. I might have missed some points. Please ask them now. Yeah.
Then regarding what are the anesthetic challenges you are anticipated for giving neuraxial blockade in a parturient patient with scoliosis?
Okay, so patient with scoliosis coming for it could be emergency as well as elective scenario. And if she's coming for an elective surgery, I'll plan it preoperatively. It could be difficult administrating neuraxial blockade in these patients because there will be difficult in identifying the landmark because the spinous processes are rotated. Usually that is a landmark used by the anesthetist to identify the particular space. However, in this case, it might not guide you to the right space. Therefore, use of an ultrasound can guide you to locate the midline as well as to assess the depth of insertion of the needle. If there is any, if the interspinal space is different, the insertion and progression of the needle can also be difficult.
What is your opinion regarding labor analgesia? If this patient wants labor analgesia, what are your problems you anticipate?
While administering the labor analgesia, I will find difficulty to palpate the spinous process as well as to insert a epidural catheter because it is very difficult to palpate as well as we cannot predict the spread of the local anesthetics, and there will be more chance for failure of the epidural analgesia while giving the labor analgesia for the patient.
So if a patient with a scoliosis coming for emergency surgery, appendectomy, or cholecystectomy, what is your anesthetic choice?
So again, ma'am, that depends upon the hemodynamics. If the patient is not stable, if has a perforated appendix or anything, if the hemodynamics is bad, I don't want to waste time on positioning the patient because it might be technically challenging. So in that case, and if the hemodynamics is not stable, then I might go for a general anesthesia. Otherwise, if time permits, I can go for neuraxial blockade as well.
So one more question: how will you manage the patient post-operatively? And what complications you anticipated?
The patient should be managed in the intensive care unit post-operatively with in continuous monitoring of vitals. Round the clock supplement of analgesia should be ensured because intrathecal.
Why it is round the clock analgesia?
Because even though we are administered intrathecal morphine, its effect can wane off in about 14 to 16 hours. Therefore, at midnight, she might complain of pain, which due to this pain can further impair the respiratory mechanics. She cannot breathe properly, which results in atelectasis and can also make her prone to infection. So I want to supplement round-the-clock analgesics following using injection paracetamol, injection tramadol, and IV opioids like morphine can be used if she still complains of pain.
So what is your idea of giving this round-the-clock analgesic to the patient?
That she should not preemptive analgesia, madam.
She will severe pain after the surgeries, madam.
What?
Severe pain after the surgery, madam. And as well as the post-operative respiratory function we want to maintain.
So what you want to do is in the day one, what you want to do for the patient?
On the day one, I'll administer IV analgesics.
For what? Why analgesia for the day one?
Because it's very painful, sir.
Very pain, I know. What is the idea of giving these post-op analgesia? Audience, കുട്ടികൾക്ക് അറിയോ? ഇല്ല.
Erasma. enhanced recovery after surgery.
No, the day one they are going to do the respiratory physiotherapy for the patient. If the patient is painful, the patient cannot do the effort. That is incentive spirometry, post-operative deep breathing exercises. So during the day one itself, we need a post-operative pain-free patient. That is the indication for giving all these types of analgesia to the patient. They're going to start the incentive spirometry. That is why it is important.
Everything will go well intraoperatively. I think, like Dr. Radha has emphasized, post-op care is also equally important. Now, there is a very good job done. You may lose some of the advantage in the post-operative period. The bell has not gone yet. Do you want to ask us any questions? No. Thank you so much then. Okay, wonderful discussion. Thank you.